Billia, who's going to tell us about Canada.
Nothing to disclose that's relevant to this talk. So before I start off talking about cardiogenic shock management in Canada, I thought we should actually have a little bit of a introduction to what healthcare is about in Canada. And in the US, I know you have the right to bear arms and the right to plead the fifth, but what we have in Canada is an access to healthcare, which is our constitutional right. Sorry, it's in my nature. I have to be a little bit flippant. And this has been a long journey for us. We have been struggling with this since 1867 with the initial British North American Act. And it wasn't until 1984 when we actually have the Canada Health Act, which really delineated how funding was actually going to be provided to the different provinces. And it's really, there are 5 pillars to this, which is really important for our Canada Health Act, and that is it's publicly administrated, universality, meaning that everyone gets access to health care, portable across Canada, accessibility is an issue, is not to be an issue, and then it's comprehensive. So anything you need should be covered by our Healthcare Act. So we have no reimbursement strategies that drives how we do healthcare in Canada. And the other part of this is actually the disparity that we have in the Canadian population and where it resides in Canada. So we have 40 million people, just under 40 million people, according to our statistics, in 2024, and you can see that they're all hovering along the border primarily. And there are pockets that are really heavily populated. And this really makes it difficult when we're talking about having access to care. And that's what we struggle with. And what, having the provinces then delineate funding and actually giving hospitals budgets, we actually only have 2 provinces that actually have funding for VA ECMO as a line item on their budgets. So what you have to remember is before this, it was Quebec, then it was Ontario, and everyone else is kind of struggling to find money to do this. And so we have challenges in balancing our hospital budgets when trying to pay for this. So when we used to, up until this fall, we were using philanthropic dollars to pay for support for patients on VA ECMO. VV ECMO was being supported since the H1N1 pandemic, but VA did not come forward until just recently. And I was talking to a colleague of mine in Edmonton, Alberta, who then tells me that they're still supporting their VA ECMO patients through a surgical budget. So we have extraordinary pressures. If, God forbid, we decide to put 2 unfunded devices in a single patient and switch around who needs to be where. And the thing to remember that across Canada, the only device that's actually funded is a balloon pump. So this is what we're struggling with, and that hopefully it doesn't play into our decisions because we really still believe it should be the right device in the right patient at the right time, but we struggle with our administration on a daily basis. So when we look at cardiogenic shock in Canada, what we've tried to do is really to try to figure out what that means from a Canadian perspective, but we've been partnering with the Critical Care Cardiology Trials Network Registry, which is a multi-sector network of CICUs in North America. And we also provide 2-month data per year, as do all the other CICUs, and it's the same across all the CICUs. 15% of our admissions are to the CICU are for cardiogenic shock. 30% of those admissions are for acute MI cardiogenic shock, and the mortality is still 40%. So whatever happens everywhere is happening in Canada as well. We're also an integral partner in the Vanquish Shock Registry, which is led by David Barron. We're one of 4 sites, and I'm very proud to say that the Canadian site, which is at my site, is the largest recruiter with greater than 90% of the patients being actually recruited to that. And we do lead cardiogenic shock clinical trials. So we're not a country that should be dismissed, that we're not really important. And an example is the DORI-ME trial that actually was published in New England a couple of years ago. Across Canada, we've actually developed a Canadian Cardiovascular Research Collaborative, which is, and within it, a cardiogenic shock working group. And really, that group focuses on research questions across Canada that it is in the area of cardiogenic shock. And one of the early things that was one of the early requests of the group was to actually get an idea of what was happening. So a national-wide survey was conducted to really understand the patterns of cardiogenic shock care in Canada. We were able to get replies back from 46 centers, and you can see where the distribution is of the centers that were actually did respond. Again, there's clusters of activity across Canada. Predominantly, you have Ontario and Quebec and a smattering of other centers. And the biggest impediment to cardiogenic shock actually care is that the lack of financial support, and that was reported in 50% of our centers. And when you look at the number of cardiogenic shock cases that are across Canada, we're talking about more than 6 cases a month. Now, that may not sound like a lot, but for some more active centers like my own, what we have is like 6 cases a week. So it really is a smattering of what's actually available. And there are differences in the types of sites that are available. We have a few sites, 9 out of the 46 that are actually VAD transplant centers, and the rest are community centers. And the variability that we saw in their survey was half of the centers actually used hemodynamic monitoring and only 10% of their patients or less. A quarter of us have a shock team. A third actually has an algorithm. A fifth really does look at quality improvement initiatives, and only a quarter actually collect data on cardiogenic shock patients. And when we look again about MCS availability, as I said, a balloon pump is available across Canada. A third will put in Impellas and use Impellas, an unfunded device, and 2/3 are using VA ECMO. And like I said, if you put VA ECMO and an Impella to do an ECPella, the phone never stops, especially at my institution. It's kind of crazy. So some of the stumbling blocks that we have in effective management of cardiogenic shock that were identified a little bit later, this is a follow-up study by Daniel Kim, was that again, same things, delay in timing of challenging patient identification and selection, lack of a systematic approach, inappropriate utilization of adjunctive therapies, lack of escalation, de-escalation, and long-term strategies, and disparity in the regional centers for access to MCS. Some of the strategies that we're working on to improve cardiogenic shock care in Canada is really these cross-Canada initiatives to collect data to lobby government. We are developing a mechanical circulatory support registry that's pan-Canadian, and we're really pushing towards education and training opportunities through our Canadian Cardiovascular Society, our continuing professional development, and really actually focusing not on the experts in the area, but really the community centers, and really trying to educate our community colleagues so that they know when to refer, how to identify early, to really build that hub and spoke environment. And we're really developing, even across our own city, a citywide shock initiative so that we can align approaches across centers, and then trying to actually expand that across the country. It's interesting that one of our colleagues in Ottawa is developing a communication app that will hopefully go live as part of a research study where we can then communicate with one another and speak the same language when we want to make referrals. So it's really exciting times for us, and I'll end there.